So I'm here to introduce Antonio. As we all know, Dr. Romo de Vivar Chavez is one of our very own residents. He joined us in 2016 after prior work at Mount Sinai in New York and also the Cleveland Clinic. He received his MD degree in Monterrey, Mexico, with electives in Oxford, England, and also Houston, Texas. He has numerous publications on inflammatory markers and immunotherapy and cancer. He's also quite a runner. I saw that he's run 9 marathons and Tough Mudder, which, if you don't know, that's essentially a half marathon, but run through like deep puddles of mud and also running up grease walls. And there's monkey bars and that sort of thing. So it's quite a challenge. And there's also, I think, electrical shocks at a few stations. So it's a pretty tough thing to do. So kudos. His next step in his career will be providing care for the women of El Paso, Texas, and he'll be fabulous at that. And today he's here to talk to us about building muscle memory and simulation training in OBGYN. So without further ado, Antonio is here, and I'm going to unshare my screen now.
All right, good morning, everyone. Thanks, Dr. Anthony, for that introduction.
Yes, thank you.
Okay. All right. So, yeah, so the topic of my grand rounds is building the most important memories in residency, the muscle memories. And this is about surgical simulation in OBGYN residency. This is a topic that I really, really like. I think it's a resource that we do use actually quite a bit in this program, more so than other programs in other hospitals that I've been. But I think that is overall a resource that is underutilized, and there's a lot that we can do with surgical simulation to improve our surgical skills. I don't have anything to disclose. Our learning on objectives today will be definition of surgical simulation, make a case for increasing surgical simulation in OBGYN, what does the evidence tells us, what is the status of surgical simulation, IUW, OBGYN, and how can we improve it? And then a few model proposals that I have of what I call rate limiting simulation. I'll talk a little bit more about that. So surgical simulation is, I mean, it's pretty self-explanatory, but it's a technique that replaces or even amplifies real experiences with guided experiences that can be immersive in nature and evoke or replicate substantial aspects of the real world in a fully interactive manner. It provides a safe and a standardizing method for training and surgery without the risks that come with operating on real patients. And to me, the most important part is, to me, the part where patient safety and skill training overlaps 100%. I want to start with this study that we actually saw a little bit of this data in one of our grand rounds about surgical coaching. This was a landmark study that was published in Michigan, in the New England Journal of Medicine from Michigan in 2013. And is one of those studies that was very important, and that it shows something that everybody already knew, but nobody had put it in paper before. They basically what they did, they had 20 bariatric surgeons record their surgery when they were doing a laparoscopic Romo. And they send their videos to the rest of the minimal invasive and bariatric surgeons to rate them. one of the things that the study showed is that, and these numbers here at the top are the skill levels of the surgeons. And as you can see, it's pretty spread across the spectrum of the surgical skill in terms of the standardized quantification of surgical skills. Portal 1 were 5 surgeons, and then 2 and 3 were 10, and then there were 5 or 25% in the top ranking for surgical skills. They measure gentleness, mostly tissue handling, time and efficiency of motion, instrument handling, the flow of the operation, the adequacy of the tissue exposure, the overall technical skill, and then a summary, an overall summary of all the surgical skills. This is the tool. This is a little bit modified from the original OSATS, which stands for Objective Assessment of Technical Skills. The domains are here, as I mentioned before. They rated these in a 5-point scale, where 1, which is the lowest score, is the surgical skills of a graduating chief residents. No offense taken. And then number 5, it will be the surgical skills of a master bariatric surgeon. And I just want to point out that your number 1 is a general surgeon that just graduated from a program, and number 5 is someone that not only has graduated and worked for a while, but also underwent fellowship training. So the spectrum is pretty wide. And then number 3 is the surgical skills of an average bariatric surgeon who's also fellowship trained. And then 2 and 4 are the numbers in between. One of the very interesting points, these group were also had been collecting for years risk-adjusted outcomes for patients. And it was nice to see this correlation that you can see on the left-hand side, where it shows a strong inverse relationship between surgeon skills and patient outcomes. You can see the surgeons had a rate of complications as low as 5%, whereas the lowest rated surgeons had surgical complication around 18%. These complications were pretty much persistent across the board. Complications overall, separating surgical complications versus medical complications, the relation was maintained. And then when you separate with type of complication, they separated reoperation, readmission, and emergency department visits, and the correlation was persistent across all the types of complications. So this is something that we intuitively have always known, but is important to have the data, because to me, the significance of this study is that it's a reminder that surgeons' technical skills matter. And what we do as individuals in the OR directly affect our patients. And one of the points that I also want to make is that once you go into the OR, you have what you have. You cannot find surgical skills and up-to-date like you can do sometimes when you forget something. This is it. What you have is the resources that you have, and there's nothing else. So we have to make the effort to go in UR every time with the best possible skills that we can develop for patients. So this slide is kind of, I just wanted to illustrate what do we do to ensure that we are adequately trained surgically when we graduate. And some of the things that I identified, we have OR feedback with cases, which is something that sometimes we get, sometimes we don't. And if we don't get it, we as residents are the only ones to blame, because if you want to learn, you need to ask for feedback. But having said that, having a systematic way to do it does help. And that's where tools like my tip report come very handy to kind of help streamline those processes. We get summative evaluations, we get case numbers, and I just wanted to highlight here the number of hysterectomies. These are numbers that recently changed. The total number of hysterectomies that we require at 85, but it just strikes me, looking at these numbers, you can graduate from an OBGYN residency with doing as little as 15 lap hysterectomies. And I know that's usually not an issue in our program, but it can be in other programs. And it's just one of the things in which I feel that the medical knowledge is tested at many levels during residency, at graduation, after graduation, and then with recertification, whereas surgical skill goes like nowhere. These numbers are a minimum that you have to have, but that doesn't prove that you can actually do those procedures. We are actually the first class in which the FLS is required to sit at the board exam, which is a good step. Is a step in the right direction, but those of you who have taken FLS, you can tell that is also is a minimum skill, but it's not something that guarantees the safety of your patients for like many of the surgeries that we do, and also it's not even geared towards gyn surgery. I can tell having done 2 years of general surgery and then doing GYN surgery, the pelvis is a whole different animal in terms of surgical exposure. There's bone everywhere. You cannot stretch the space. So I found it very challenging after doing surgery to just operate on the pelvis. So the standards that they have for general surgery are very different. And by the way, and then there's continuous medical education, in which you go and go for a weekend for an intensive course to kind of refresh a skill that you may not use for months. And it's just, I think it's not the optimal way to keep your surgical skills up to date. And this is not only for OBGYN, this is like for every surgical specialty, which is not very good at quantifying or testing the surgical skills of the providers. So kind of going back to this chart, you may wonder, these high rate of surgical complications may be high because this study was done with general surgeons and bariatric surgeons who only do surgery, what are the rates of complications in OBGYN, and what are the rates of surgical complications at UW? I don't have those numbers, unfortunately, but what I do have is the cases that we thought were worth discussing in M&M. These are cases that were submitted for discussion in M&M from June 2018 to June 2020. And you can see them in this chart. They were 33 medical complications submitted, 111 surgical complications submitted, and then there were 76 cases that were just like interesting cases, but not really complications. So when you plot them, you have 77% surgical complications and 23% medical complications. Now, some of these could have been avoided, some of these were unavoidable. I run the numbers trying to just judge on these complications to see the proportion was maintained with any modifications that you will do. So I want you to just reflect on this and just think, how much time do you put as a resident and as a provider on trying to improve your surgical skills given the number of complications that we have? And these are not higher. I think I'm not trying to say that we have a high number of complications. On the contrary, but I'm just trying to illustrate how much time we dedicate doing questions, reading articles, reading journals, which we continue to do, but we should be equally worried about practicing our surgical skills, because this is where patients are getting, these are the outcomes that we're getting, at least from the review from the M&M case submissions. Simulation stimulates motor skills. There's unfortunately not a lot of evidence of what is the optimal training time that we need, what are the means that we need to use to acquire these motor skills, and for surgical training. There's a lot of data in other areas, such as athletics and psychology, in which motor skills have been studied for a long time. And we can extrapolate and we can learn from that they have, and hopefully we will have more strong data for surgical skills in the future. And in the area of psychology, this is a concept that I found very interesting, is the concept of brain bandwidth. Everything that we do occupies some bandwidth, and the more we do things, the less bandwidth those things are going to occupy. Things that occupy very little bandwidth in your brain are things like walking, drumming your fingers or tapping your foot on the floor, or things that we are experts at because we do them very often. Things that occupy a lot of brain bandwidth is talking, listening to information, doing anything that we have to concentrate hard on, doing things that we're not expert on because we don't do them very often. If you think about it, if you are in the OR and you're doing a new surgical task, and it's taking half of your bandwidth, and then you are with a patient on the table, and you have your attending, and they're just watching what you're doing, you occupy most of your bandwidth, and then you have very little left for everything else. And this is something that I think I mentioned this before, but I think that it's nice to be pimped and it's nice to be questioned, but I think that when you're trying to do a new surgical technique in the OR, is not the right time, because you are either going to do one or the other, or you're going to do poorly in both, because you just don't have that muscle memory and that brain bandwidth to be able to deal with trying to make a good decision and then trying to make a surgical procedure the right way. And there's also consequences on saturating your brain bandwidth, and to just name a few: exhaustion, mistakes and forgetfulness, loss of executive control, and loss of cognitive ability. And I think those are pretty important when you're doing surgery. So now there's been a lot of studies. Can we increase the bandwidth? Probably not. We can, however, decrease the amount of bandwidth that a particular task uses, and simulators can help with that. You can also get there by just operating, but there's a lot of damage that can be done on the way. Simulators provide a safe and standardized method for training without the risk that come with operating on real patients, and without an attending looking over you, so you have a little bit more bandwidth to kind of relax and focus. It promotes the acquisition of a competency and procedural skills. It promotes team building. It promotes communication skills with an educational focused environment. And this is how I pictured a surgical simulation. So the stress still there. If you've been an hour practicing suturing in a simulator, it's not a video game. It is tedious. It is boring. It does take some toll. It's tiring. If you're having fun and it's very easy, it's probably not helping you. You need to, step it up and get a more difficult task. But you have your bandwidth for the surgical task, and the stress of the simulation is not as much in the OR. So you have plenty of room for other things, like team building. This is probably a good time to get your communication skills in the OR. This is a good time to try and learn how to communicate using the right words, topographic anatomy, and the right terms to orient yourself in the surgical field. This is when you where's caudal, where's cephalad, and this is something that you should practice also when you're doing simulation, because this is when it doesn't matter if you mess up. And then there's time for real-time feedback, there's time for pimping, and there's a little bit of time left there that I don't put, where you can drink your coffee while you're doing this, or whatever else you want to do that you cannot do in the OR. This is where you can do these things and then learn at the same time. There's also things that we can do with a simulator that we cannot do in the OR, and there's a few described learning principles for motor skills, and the way in which the training is delivered, how, when, what, and how often is equally important. In many programs, junior residents will learn a particular skill 1 week and return the next week and learn a different skill, and there's very little opportunity to apply the skills that you gained, and sometimes you never go back even years after you learned that particular skills. Same goes for CME programs. When you take a day or a weekend course, there's no time for rehearsal of the skills, and there's a very large period of rest that hasn't lasted by the time you have to use that skill. There's also in athletics specifically, there's this concept applies to many areas, but specifically in athletics, there's good evidence that practice interspaced within periods of rest, which is what they call distributed practice, leads to better acquisition and retention of motor skills compared to practice delivering a continuous blocks with little or no rest between, which is what they call mass practice. I'm sorry. And this is important for like my last bit of this presentation when I talk about the rate limiting simulation, which is a thing that I came up with, but I think that is very important to practice a small piece of a motor skill as opposed to practice the whole procedure. There's advantage to both, but I think that we're actually very good at the program at doing the larger procedures. We have great simulations during the Thursday University that we can do a whole hysterectomy, we can do urogyne repairs, and those are very useful, especially because we have the faculty, we have the experts there. But when it's not Thursday, when it's the daily basis, when there's not an attending, I think that the most worthwhile of our time is to do small exercises. This is a quote that I really, really like. This is from basketball. I don't know if anyone knows who Team Groven is. Great players aren't great because of the highlight plays that happen. They are great because they do the basics better than anyone else. They work harder at the basic skills than anyone else, and they become extraordinarily skilled at the ordinary things. Tim Groven he was a trainer for like 15 years for Michael Jordan. And this is one of my favorite quotes, and I think it's very true, especially for surgery. So I ran to this quote, and it made me wonder how is it training for a basketball player? And I went to this webpage, Breakthrough Basketball, and I was just looking at basketball drills and kind of see how they distribute their practice, because basketball is, in most sports, is motor skills for the most part. So they have many drills, but these ones have like been run through like NBA data analytics. The most effective drills that you can do, the best use of your time. They actually have a lot of data that they do to come up with this, but they separate offensive drills, rebound drills, team offense drills, defense drills, and athletic development drills. So I went ahead and looked at the offensive drills, and they divide those in dribbling, footwork, layup and finish, and shooting drills. So I went ahead and looked at the shooting drills, and they have another 6 categories: individual, form shooting drills, partner shooting drills, dynamic shooting drills, game-like cut drill, and basketball decision training drills for shooting drills. So then I went ahead and looked at each category of those, and this is how much they have. And keep in mind that this is just one of all these branches. They have hundreds and hundreds of them. And then I went ahead and clicked on one of these, and they have a whole instruction for the drill. They have training tips, they have a diagram, and they actually have a video for each of these individual drills. And I'm looking at this and I'm thinking, this is what we need. There's no reason why we shouldn't hold ourselves to the same standards, because we are in the business of medicine and taking care of patients, and this is pretty intense. We should be more intense than them. I thought it was pretty impressive what they have there. So what would Ob Gyn Residency Drills, surgical drills, look like? This is something that I already told you. I think that we benefit a lot from, just like we benefit a lot from a grand rounds, learning from an expert in a very specific field. We benefit greatly from the Thursday University SEAM sessions with guidance from experts. But we also do read articles. We also do TrueLearn. Where is the equivalent of TrueLearn in surgical skills? So my proposal is to add, and this is something that Dr. Basuto asked me last week, what suggestions we had for our didactics in residency going forward. And one of my suggestions is to incorporate a SIM session on a weekly basis. In the Merger Gyn, when we have our 7 a.m. didactics, one of the days of the week should be for surgical simulation. And actually, when I was Gyn chief, that's what we used to do on Friday teaching session. I think the residents liked it, and I got good feedback from it. And it's also very relaxing, like fun time for the junior residents to ask questions and to even try something that is a little bit above their level, and they can start kind of getting their more advanced skills early on. Meritor OB, I think that we're in the process of deciding what time is the didactics gonna fall in a daily basis. I think that we also should have a time during Meritor OB for at least one day a week to do some surgical simulation. And just as a side note, it would be nice if the Sim Lab is available for Sim. When we were on Gyn, we were like trying to whisper, and because OB was doing sign out, and I was telling Ramsey it should be them whispering, because the Sim Lab is not a conference room. That was just a joke, but yeah, it should be like a space where we can like do what we need to do to learn. Oh, let me see if I can make this work. 1 second. So I have a poll that I wanted to share. I'm gonna try and like. Oh, here. All right. I'm gonna have the residents fill out this poll. And the question is, how comfortable do you feel performing the following tasks? And then you're gonna rate it from A through E. A is the worst, I can perform. B is beginner. You can do it with significant help and supervision. Intermediate is I can do it on my own with some supervision. B is I can do it without instruction, but I will need help if there's complication. And E is expert level. You can do it and you can deal with most of the possible complications. So let me see. I don't know if you guys can see this poll.
We can see it on the side now. Yay.
Okay. All right. So you can just go the first one.
I don't know how you're clicking it. Anyway.
I don't know if you can. I think you can just click on the answer.
Oh, that does seem to work great.
So for the rest, this one is for the residents. How comfortable do you feel with patient positioning? And then the second one is Foley placement. If you can just like start clicking through them, it will take like a minute. The third one is Verus needle and pneumoperitoneum. Number 4 is stroke replacement. Number 5 is dissection of broad ligament. Number 6 is isolating the ovarian vessels. Okay, looks like they're coming. Number 7 is pulpotomy. Number 8 is laparoscopic cuff closure. All right. So here a few more seconds, and then I'm gonna close it and see what we got. All right, looks like it's compiling the results. All right, so this I figure I want to do this to kind of illustrate. Unfortunately, it will take the total of the audience, so the bars are not going to be very long, but you can tell what the residents feel comfortable with, and you can start. You can kind of see. Nobody feels, or very few people feels. Nobody feels a beginner on positioning the patient or placing a Foley catheter. Most of the residents feel expert, and I'm proud of you. Then Verus needle, most of the residents feel proficient. A few feel expert, and then there's a few that feel beginner, which is, I think, is kind of expected for that skill, given that the interns haven't had a chance to do a lot of laparoscopy. Same for trocar placement And then dissection of the broad ligament, that's a little bit more distributed from what I can tell. And then colpotomy, there's a lot more beginners in colpotomy. And then laparoscopic cuff closure, there's no experts, there's 3 proficient, and then the rest are either intermediate, beginner, or about my pay grade. So I think this tells you where should our efforts be. Where if you are going to design a simulation session, it should be geared one to where the residents feel like they are. And you can separate, the right way to do this is separate these by class and then do a curriculum by class. But at the same time, the classes all together is rarely all together in the same place. So this kind of brings it all together, and this is something that we can use to design 1 or 2 simulators for the Gyn rotation. We can do a similar one for like OB skills and kind of design little tasks that we can practice on a weekly basis and try and get these numbers, a little bit more to the proficient level for a particular skill. And this is obviously what you feel comfortable with. And, it's like when you're holding the camera, you may feel comfortable with holding the camera, but the surgeon may feel nauseous when you're holding the camera. So, and that's why I have a second poll and to see what the faculty thinks, the residents, what the faculty thinks where the residents are. So this is a second poll, and this is for the faculty to answer, and I'm gonna bring it up in a little bit. So the question is, at the end of the academic year, which aspect of comparative performance has the most room for improvement? And I have 4 categories, and this is from the surgery assessment tool. Respect for tissue, time and motion, instrument handling, and knowledge of procedural steps. For tissue handling is uses unnecessary force, cause damage with an inappropriate use of instruments, and the best is handles tissue appropriately with minimal damage. Time and motion, many unnecessary movements on the bad side, and then on the more professional level, clear economy of movement and max efficiency. Oops. That. So let me bring that up. And this one I did separate by class because obviously it varies widely depending on the level of training. All right, so let me see if you can see this poll for the faculty. It looks like, I don't know if you can see the whole question, but the first question, and they're all the 4 categories. The first one is for PGY1s, the second for PGY2s, and so forth. just gonna give it a few minutes, and then we'll see what we get. All right, I'm gonna close this and okay. So this one kind of expected. Looks like for the PGY1 level, there's obviously room for improvement in all the surgical skills, and that's why you're in residency. And as you advance to second, third, and fourth year, and I kind of suspected that because this is a feedback that we constantly get. The oh, let me see. Sorry, I don't think I was sharing the results. Can you see the results now? Okay. All right. So yeah, the PUI1 is kind of like distributed between all the categories, and then as we advance, kind of like the more prominent becomes the time in motion and efficiency in motion. It is a skill that takes time to master, and you know, even when you know how to do something, you know what to do, getting to do it faster, getting to look less clumsy, and refine the movements is something that just takes time. But I think it's also very helpful to kind of see this and know where you can focus the design the simulation schedule or program for the residency. Okay. So, and I'm gonna kind of just go quickly through this. The purpose of this talk was not to go through like the technologies. The technology for simulation is very, very wide, and it goes anywhere from like single machines to very like high tech simulators. But the purpose of all of them is to enhance the psychomotor skills and our hand-eye coordination, ambidextrous surgery, and also there's a very high focus on laparoscopic surgery and endoscopic surgery just because of the nature of losing the three-dimensional vision. These many kinds of simulation have been proven to be effective. These two studies that I'm quoting here, they showed that trainees doing simulation trainees were randomized to do simulation or traditional training for laparoscopic surgery, and then they were assessed during laparoscopic cholecystectomy. And the group that was in the simulator was 27% faster and had it was 5 times less likely to make errors and 9 times more likely to make progress. Other studies show similar results. The these are just some of the different kinds of simulation. You know, it goes anywhere from wet labs involving live animals, which I'm you know, still not sure how I feel about it. They're certainly very helpful, and that's, you know, that's the reason why I'm not sure how I feel about it. But there's virtual reality computer programs. I don't know if you guys had a chance to use the ultrasound simulator that we have in the same labs, but if you haven't, you should, because it's pretty amazing, and we're very lucky to have that simulator. And there's even virtual hospitals like the Medical Simulation Center in Loma Linda University in California that has ambulances, and they have like an ICU, they have ORs, and they went kind of crazy with it. This is one of the things that I wanted to talk to you about, and one of the reasons that I made those polls, because these are some simulators that I've made, but these are only based on my own personal weaknesses. This first one was inspired by Dr. Alniami after I had like 5 aeronauts in a row, and he will immediately call every single one of them. So I felt that there was no way I could be a 3rd-year resident and still be doing aeronauts. And so I designed this simulator, which is nothing but 2 strings and 2 pieces of plastic, but it will not let you, you know, if you don't put the right tension in the knot, if you don't lock your knot, it will just open it up. And even this one that I was doing for demonstration, that's a little bit of an aeronaut too, but well, that's why I have it to keep practicing. It's also held in these pegs. These pegs come with the lab trainer that I think I don't know if they give them away still, but there's a bunch in the same lab. You should grab one while they're still there. And the reason I put it here is that if you put too much tension on your knot, this is just gonna pop out. So you also need to be careful not to put a lot of tension, and that kind of helps you practice, you know, not to evolve a artery that you are ligating. This is a half closure model. This is a silicon a piece of, I think it's like a door seal, the thing that you put underneath the door to keep, I guess, dust or bugs from going in your house. But I liked it because it has 3 layers. So when I'm doing the laparoscopic suturing, I need to make sure it goes through the mucosa, the muscle, and then the serosa. And I look at it every time I do a stitch. Dr. King has a very nice model for laparoscopic closure of the cuff. It's made of fabric and is being validated by MIS surgeons. And it's very useful if you haven't done it. There's a few there in the same lab, and you should start with that one. But once you are comfortable with that one, my main issue is I practiced the fabric one, and then when I was in surgery, I couldn't get the needle through the tissue easily, and that's why I felt that I needed something that would put more resistance. If you close this one and you keep it closed, this is like way harder than an actual vaginal cuff. So, and that's why I like it, because you should like challenge yourself. The simulator should be a little bit harder than the real life, in order to like give you a real advantage. And I put these in a PVC pipe and then just zip tie it to these cheap plastic. This is
Hey, Antonio, this is amazing. I just want to give you a heads up that we're right around 9.
Yeah, I think
this is fabulous. You can keep going, but people may need to kind of step out.
Okay, thanks, Dr. Anthony. So this is the last one. This is an Alexis tissue extraction bag that I made out of the Ziploc, and these are my fibroids. They're just like sponge balls, and we practiced a few times to do the excite technique, and this was very useful too. And this is just an operation game that we put inside of one of the lab trainers, and then connected the cable to the laparoscopic instrument, so you can so it buzzes when you mess up, when you touch the metal. So I'm gonna open it for questions. Sorry, I went a little bit over.
All right, great. That was a great job. Amazing. I particularly like that you analyzed our M&M sessions for for complications. You know, that might be you know, worth looking at in these poll results. I think there have been multiple requests to share the results of today's poll, if you were able to track that somehow, you know, what the residents thought they could improve and what faculty thought residents could improve. So if you have a question, please type the word question or a question mark or, you know, something into the chat box, and I'd be happy to call on you so you can unmute. All right, so, oh, here we go. Christine Heisler, would you like to unmute for a second?
Hi. I just wanted to tell you, Antonio, you did such an incredible job. This is really looking at surgical simulation and how to do skill building, and when our OR times are limited and surgical volume is reduced from where it was previously. Fantastic ideas, just really incredible. You should be really proud of yourself.
Thank you. Thanks, Dr. Heather.
Great, and Stephanie Peace has a comment as well.
Oh, my comment is just thank you for being such an excellent surgical educator for junior residents.
And next, Erica has a quick comment.
Yeah. So again, thanks. That was a very interesting presentation. And I just wanted to, I guess, kind of editorialize that I do also think part of things that we need to work on with our simulation is, and like you were talking about with that not example, the kind of validity of it and what you're practicing. As far as like with, because I think you can memorize incorrect muscle memory is, if we don't set up things right. So like with vaginal cuff closure, you were talking about how the fabric was too easy to go through. I found that when I sit in front of a laparoscopic box trainer and I have one instrument on either side, the angle is much easier than if you make sure both your instruments are off to the side. And it took me a long time to figure out that that's why I was having that incorrect muscle memory. And then also with the very awesome robot simulator, I know like for our to pass, we just need a certain percentage, but you can always like have that big red X in, you know, time or economy of motion, and you can still pass overall. But I think making sure that you get the green check for each of the subcategories actually makes a big difference in what you get away from the simulation. And thank you again. That was very interesting.
Thank you, Erica. Yeah, I think you're right. I always and we should actually just go to the SimLab and flip all the boxes sideways, because that's how we should be practicing. You know, only general surgeons stand in between the patient's legs because they operate on the patient upper abdomen. But we should be standing on the side, and we should have our boxes sideways. I completely agree with you. I always tell the students once they start suturing on their little suturing kits, they're not allowed to touch it, because they always they take a stitch and then they flip the thing and they take another stitch. So they're always super comfortable. And when they are in the surgery, they cannot flip the patient and they struggle. So yeah, I totally agree with you.
Yep, and Bhagavath has a comment.
Hi. Yeah, I just couldn't agree more with that. I think that's the biggest problem we have let ourselves into is standing in front of the TV screen and as though we are straddling the patient's head and operating, which we never do. So we operate in the pelvis, but we are standing on one side. And that's something that I cannot encourage more for everyone to do from the get-go.
Thank you. Thanks, Dr. Romo.
All right, it looks like that's all the comments and questions. So great job. Thank you for sharing this grand round, Antonio. And please feel welcome to share those results if you're able to extract them and share with the department the survey results from
Yeah.
today. So.
I've never done that before. I will try. I will see if I can do it. But yeah.
Alrighty, well, thank you. Take care. Bye, everybody.
Thank you.